All right, good. Now with that out of the way, it is my absolute pleasure and honor to introduce our Moody lecturer for this afternoon. This is a individual that I've admired for decades, quite frankly. So it is a deep pleasure for me. Peter Angelos is the Linda Kohler Anderson Professor of Surgery and Surgical Ethics, Chief of Endocrine Surgery, Director of the McLean Center for Medical Ethics at the University of Chicago, a native of Plattsburgh, New York, where his father was a community general surgeon. Dr. Angelos completed his undergraduate degree, medical school, and PhD in philosophy at Boston University. He completed his residency in general surgery at Northwestern and went on to complete fellowships in clinical medical ethics at the McLean Center of the University of Chicago and in endocrine surgery at the University of Michigan. Dr. Angelos is a busy endocrine surgeon and also seems to take on the toughest endocrine cases, by the way, who has written widely on improving outcomes of patients having thyroid, parathyroid surgery, minimally invasive endocrine surgery, and the ethical aspects in surgical innovation. He has played a major role in national and international recognition of the importance of surgical ethics to the practice of surgery, and he has been the lead initiative to train over 135 surgeons in clinical medical ethics at the University of Chicago's McLean Center. Dr. Angelos has over 310 peer-reviewed publications and has authored or co-authored over 55 book chapters. He co-edited a book, Difficult Decisions in Endocrine Surgery. Of course, that begs the question of what are the non-difficult decisions in endocrine surgery, as well as editing 2 editions of the book Ethical Issues in Cancer Patient Care. He is also the co-editor of Difficult Decisions in Surgical Ethics and the American College of Surgeons textbook Ethical Issues in Surgical Care. Dr. Angelos was also a regular contributor to the ACS Surgery News, where he wrote a column on surgical ethics entitled The Right Choice. From 2011 through 2019, Dr. Angelos had leadership positions in numerous medical and surgical organizations. He is a counselor of the American Board of Surgery, chair of the Complex General Surgical Oncology Board, former member of the American College of Surgeons Board of Governors, and member of the American Thyroid Association's Board of Directors, and past president of the American Association of Endocrine Surgeons. So it is with great pleasure that I call Peter Angelos up to give us his presentation.
Thank you. Thanks, Dr. Volanovich. It's really a true honor and a pleasure for me to have the opportunity to give this talk. And sadly, I have no disclosures, no financial disclosures, because industry does not really support ethics, so sorry about that. Someday I hope to have disclosures, but I do have some disclaimers, and it is important that you know what those disclaimers are. First of all, you heard I'm an endocrine surgeon. I am also board certified general surgeon. I took general surgery call up until a few years ago, but this is only the second meeting of SSAT that I have ever been to, and so it's really an honor for me to be here. The other thing that's valuable for you to know is that there isn't a whole lot of evidence to support the things that I'm going to tell you today. Now, that being said, mostly it's my opinion. I am absolutely convinced that my opinion is correct, but you may disagree. And so I'm specifically going to leave time so that we can have some discussion, because that's what is important in ethics. In addition, it is important to recognize that frequently you go to a named lecturer at a meeting like this and you expect that you are going to come away with the answers to the important questions. With an ethics talk, I want to set really low expectations, okay? And this is really the secret to my entire career, which is low expectations, okay? So if you leave with more questions than answers, I feel that I will have done my job, because that's the way ethics is. So that said, I really do want to give special thanks for the honor of giving this Moody state-of-the-art lecture at the SSAT. I never knew Dr. Moody, but I do know of his legacy and have actually done some reading about him and his many, many contributions to not only the SSAT, but to surgery in general. I also want to acknowledge that when I was a surgical resident, Dr. David Narwald was my chair, and the SSAT was incredibly important to Dr. Narwald, and thus as a resident, I sort of looked at this organization as being really a very, very important organization, and I'm still indebted to Dr. Narwald for actually picking me to match in surgery at Northwestern, because I don't think I was actually good enough to get into that residency. But nevertheless, over the last several months, since I received this wonderful invitation to give this talk, I did some review of PubMed, trying to find some overlapping interests between mine and Dr. Moody's. From a clinical perspective, it was difficult, I have to be honest. And so this is a 1966 article, Aldosterone Effect on Canine Gastric Juice. I have no idea what the effect is because I could not get this article, but this is the only area of clinical overlap I could find between Dr. Moody's clinical and research interests and mine. That said, I do think that we have a lot of other overlapping interests, and that has to do with the education of medical students, the education of surgical residents, improving patient outcomes, and a commitment to advancing the art and science of medicine. And so I hope that I will be able to honor those overlapping interests as I give this talk. So by way of outline, I'll talk a little bit about what is surgical ethics. I'll address some of the distinctive features of the surgeon-patient relationship, which I think are important. Some of the criteria for informed consent, because informed consent I do think is sort of the pillar of surgical ethics. And really, I'll talk some about the basis of responsibility that surgeons have to our patients, and how the ethical dimension of surgery might mitigate risks of burnout, and then finally, some prospects for the future. So, we all know about medical ethics. It's been around for a long time. Even when I was in medical school, which is now increasingly a long time ago, there were courses on medical ethics. I took a course in medical ethics. Surgical ethics, much more recent concept. I have to say, many people, when I initially said, oh yes, I'm very interested in surgical ethics, would make comments like, isn't that an oxymoron? And things of that nature. I have to say, it is interesting. You heard that I went to Boston University, and I was originally in a BA MD program, and then I went into an MD PhD program. I was getting my PhD in philosophy, and so that was adding extra time to the program, so I was there for a number more years. But I do remember vividly in 1988, I went to talk to the dean of students to get my dean's letter. This is what I looked like. This is from my medical school yearbook. So young, so naive. Honestly, it's hard to believe. But I went to the dean of students and I said, I have decided to go into surgery. First of all, I think he was relieved that I was going to graduate, number one. I think that was a huge relief. But I'll never forget the fact that he burst out laughing and said, after spending so much time studying philosophy, why would you go into a mindless technical discipline like surgery? And so, that's really stuck with me over the years. And I've come back to it many times. And this question, is surgery a purely technical discipline? And I would argue that regardless of the type of surgery one does, technical mastery is absolutely necessary. but it is not sufficient. There's more to it. And I hope most of you already perhaps agree with me to some extent, but I'll try to give you some additional reasons why I believe that is the case. So, I think it's interesting to look at where we have come from and some of the historical views of the patients' relationships with their physicians and surgeons over the years. And so this is a really famous portrait by Sir Luke Fildus, the doctor. It was on the cover of my medical school textbook. In fact, it's sort of ubiquitous in medical education, this portrait. And although I am not an art historian, I would say if you look at this, the doctor is portrayed as being thoughtful, caring, concerned about the patient, seems to be very trustworthy. The parents are in the background. They seem to trust the surgeon. And in fact, the doctor is welcomed into the home. And so this is sort of it's a warm scene that is portrayed in this portrait. Now, what about the surgeon? Well, if you look similar time frame, the surgeon is portrayed very different, right? So the surgeon is brutal, ignores patient suffering, struggles against the patient, and operates in scary places, namely the operating theater. So big difference between how the surgeon-patient relationship is portrayed compared to the physician-patient relationship. Now, it is valuable to note that prior to the development of anesthesia, speed was an essential aspect of surgical practice. And so this is from a 1517 surgical textbook, and it shows a battlefield amputation. And this is what a lot of surgery was, amputations, because, of course, we didn't have antibiotics. And no question, speed was very, very important. It did occasionally lead to unfortunate outcomes. And Dr. Robert Liston, a famous surgeon in London, was known for his speed and bravado. This is a portrait of Dr. Liston. He is described as being a giant among men. It appears he was maybe 6'3", really, really tall in those days. And his most famous case, reportedly, he did a leg amputation in less than 2.5 minutes. Now, if any of you use DuraPrep, you know it's 3 minutes on the clock for DuraPrep, right? So by the time we're done waiting for the DuraPrep to dry, he's already done this leg amputation. Unfortunately, the assistant who was holding the leg lost 2 fingers. The patient died of gangrene because there was no antisepsis. The assistant subsequently died of gangrene, and Liston slashed through the coat of a spectator who was so terrified that he reportedly dropped dead of fright as well. So I'm just imagining the M&M conference, right? 1 operation, but 300% mortality, right? So just imagine that. Now, certainly after the development of anesthesia, surgeons changed as well as surgery. And so this is from the famous Eakins portrait, the Agnew Clinic. And here you see Dr. Agnew is lecturing to the medical students and the residents, right? With the patient asleep, the operation can take as long as necessary, or if you're an anesthesiologist, longer, right? Now, very different now. Instead of it was speed, it was much more about finesse and meticulous technique. That's what was really emphasized. And there was a period of time when people thought, well, the surgeon-patient relationship is going to become sort of a thing of the past because patients were asleep for their operations. And the number of medical students who come to the OR, and when I ask them, what are you interested in? And they say, well, I really like surgery, but I like talking to patients, so of course I shouldn't go into surgery. They miss the fact that, without question, the patient experience with general anesthesia is very different than prior to the days of general anesthesia. But in fact, general anesthesia creates the ultimate vulnerability and trust in the relationship between the patient and the surgeon becomes even more important. Now, we all know that there are many, many differences between medicine and surgery, but I think one of the fundamental differences is that surgery requires us to harm our patients in order to have even the potential to heal them. And that's a big difference. In addition, the healing cannot occur without an intervention that would be illegal in any other context. So, again, as an endocrine surgeon, I do lots of thyroid and parathyroid operations. And so for many years, my kids would tell their friends, "Oh yes, Dad cuts people's throats for a living." And it didn't always go over well. But of course, things are different when there's informed consent and we're in the operating room. And the other thing that's really very important for us to recognize is that the relationship between the surgeon and the patient is physically very intimate. We know things about our patients that they will never know about themselves. Namely, what does the tumor look like? The number of people who say, "Can I take home my thyroid?" It's sort of strange to me, but nevertheless, the idea that there's something there that they will never see. Of course, I can't give it to them, but I take pictures. So let me touch on two what I think are important and distinctive features of surgical ethics. So first of all, we'll talk a little bit about informed consent and then a little bit about the nature of responsibility. So, you heard this morning, Dr. Rael gave an outstanding presidential address in which she talked about informed consent. And we know that informed consent is based on respect for patient autonomy, and that's a good thing. We're all in favor of that. We generally have a relatively short period of time in which to obtain the confidence of our patient, to educate our patient about their condition. And patients actually have to have so much trust in us, their surgeons, to allow themselves to be put to sleep in an operating room and to allow us to do things to them that are potentially harmful and disfiguring and may lead to complications and death. And again, we would go to jail for the things we do if it were not for informed consent. So informed consent is very important. Now, we know that traditionally it's based on an explanation of risks, benefits, and alternatives. And if you have a patient who has the capacity to make decisions, or there's a surrogate, for example, for a child, of course, we know it would be a parent, then we engage in this informed consent process and we have permission. And in emergency situations, again, it's valuable to recognize that when a patient cannot give consent, it's not that we ignore informed consent, but rather we use presumed consent. We assume patients would want us to keep them alive. So, how should the quality of informed consent be determined? Well, traditionally, it has been the assessment of the patient's knowledge of risks, benefits, and alternatives. But multiple studies actually show that most patients do not remember what we tell them. Even minutes after we finish explaining things to them, they don't remember at least half of it. So my partners and I did a study once where we explained an operation, the patient signed a consent form in the office, and then the surgeon walked out and a medical student researcher walked in and asked the patient a series of questions about risk, benefits, and alternatives. And they got less than 50% correct. And lots of studies show similar type of data. Nevertheless, there is a high degree of satisfaction in the consent process by most surgical patients. And so to me, it raises this question, how can there be this discrepancy where patients remember little of risks, benefits, and alternatives, and yet they remain highly satisfied with the informed consent process? So to me, it it raises this question, which is information transfer the true measure of success of informed consent? And I would actually suggest that the answer is no, that it's actually patient trust that transcends these problems with memory, and that trust, the patient's trust in us, is actually the basis for informed consent. And we do know, lots of data shows that surgeons trusted by their patients are less likely to be sued despite having complications. Now, not being sued is not sort of the standard for what is ethical practice, but it's not a bad thing to not be sued. So I think we have to recognize that. So informed consent, then, I would argue, means much more than this checklist of risks, benefits, and alternatives. And again, good data is essential for informed consent. We have to know what the risks are. We have to be able to explain that to our patients. But that's not enough. Patients have to trust their surgeons to place them at significant risk in order to have this possibility of benefit. Now, this idea, this way of looking at informed consent raises some cautions. So it is not enough that we be able to rapidly engender our patients' trust, and our goal should not be to gain trust without basis for trust. And again, to emphasize, we should not strive to educate residents, fellows, to be outstanding hucksters. This is not the goal, right? We're not trying to teach people to be snake oil salesmen, to engender trust when there is no basis for trust. But what patient trust demands of us, I would argue, is that we be trustworthy. And that means we have to have the patient's benefit at the forefront of our decision-making when we are recommending treatment. And that, I would argue, is the basis for our ethical commitments. So trustworthiness, then, is what I would argue it's really all about. Now, what does it mean to be trustworthy? Well, that's a complicated thing, and it includes things like having honesty and integrity, acting with reliability and dependability, having competence and expertise in what we do, showing empathy and compassion to our patients, and treating them with openness and transparency. All of these things, I would argue, are absolutely critical to us being trustworthy. So what about this issue of trust and trustworthiness? I would argue trust is something that has to be earned. A surgeon cannot simply declare themselves to be trustworthy, but rather they have to demonstrate it. And rather than lowering the ethical bar by grounding informed consent in trust, I would argue that we're actually raising the bar. And this is something that when I talk to ethicists, they say, well, if it's not about information transfer, then somehow it doesn't fit the paradigm. But I would argue that gaining trust and ensuring that we're trustworthy makes this process more demanding rather than less demanding. Let me turn for a moment now to talk a little bit about responsibility, because I do think responsibility is critical to what we do. Many of you are familiar with Dr. Franny Moore and his book, The Metabolic Care of the Surgical Patient. And I'm indebted to Dr. Jerry Doherty, who prompted me to look this up. In the very first paragraph of the introduction, Dr. Moore writes, "Surgery is responsibility. The fundamental act of medical care is assumption of responsibility." And I do think that this is very true. Now, what others have said about responsibility, I think is also valuable, and in particular, a sociologist's view of surgeons and responsibility. So this is a great book I would highly recommend to any of you who are interested. Charles Bosk was a medical sociologist. He wrote this book, first edition, 1979, Forgive and Remember. The second edition came out in 2003, and it refers to Pacific Hospital. Now, Dr. Bosk was a graduate student in sociology at the University of Chicago. So Pacific Hospital is actually the University of Chicago Medical Center. And all of the surgeons have pseudonyms, but if you talk to the people who have been around there for years, they could tell you who each of those people are. And so it's very interesting. None of them are still practicing. Nevertheless, there are lots of great stories. Bosk spent a whole year following the surgical residents around, learning how surgeons take responsibility for the outcomes of their patients. And in particular, he spent a lot of time at the M&M conference. And I'm going to just quote what Bosk said because he described it more eloquently than anyone I know. He said, when the patient of an internist dies, the natural question his colleagues ask is, what happened? When the patient of a surgeon dies, his colleagues ask, what did you do? By the nature of his craft and his beliefs about it, the surgeon is more accountable than other physicians, and he also has much more to account for. Now, I think this is very true, and it does raise the question for me whether this high degree of responsibility for patient outcomes makes burnout more likely for surgeons. And perhaps it is this responsibility that puts us at greater risk. Now, mind you, it is not bad for surgeons to take responsibility for their outcomes. We all know that if we are not bothered by our complications, we're not in a good place. We should be bothered by them. But this does create challenges to recognize the value of taking responsibility and yet not be overwhelmed by them. And I do think it's, again, important to reflect on the impact of complications on surgeons. Lots of studies have pointed out the serious impact on surgeon well-being that complications have. Some people have described this, the surgeon as the second victim of a complication. And lots of institutions have instituted peer counseling programs to try to mitigate this issue. And undoubtedly, these are important because obviously we know burnout is a real problem. It's an important issue for surgeons as well as other physicians. And truly, I don't know. Sometimes people say there's an epidemic of burnout, maybe, but there's also definitely greater awareness of the issue. But whether it's an epidemic of awareness or an epidemic of burnout, either way, we have to pay attention. And there's no question that burnout is a risk factor for depression and suicide, and approximately 400 physicians per year in the US commit suicide. Truly an astounding number, right? That's more than a large medical school class wiped out every year by suicide. So a big issue. And there are certainly lots of potential factors associated with surgeon burnout. Some of them, loss of autonomy, important, no question, perhaps a diminished sense of value in clinical activities. Maybe the electronic medical record adds to that. I'm not sure. Some people have argued inclusive language may, in fact, devalue individual physician contributions. And in particular, if we are all called providers, that would suggest that, I as a surgeon am just a cog in the wheel rather than an essential actor. And that, I'm replaceable because I'm just another provider. And there's hundreds of providers. I'm not sure that that's true because from a patient's point of view, their surgeon is important. And most patients who have had surgery often define their life relative to their operation, well, before my surgery and after my surgery. And so it is a big deal. Now, could there be aspects of surgical practice that increase resistance to burnout? Well, I think that by emphasizing the ethical dimension of the surgical care of patients, there may be benefits not only to our patients, but also to us, surgeons. So what then is the ethical dimension of surgical care? Well, this is the non-technical aspects of surgical care. This is things like communication with patients. It is the surgeon-patient relationship that we talked about. It is the importance of the trust that our patients place on their surgeons, and things like shared decision-making. Well, how might this attention to the ethical dimension then affect surgeons? Well, it seems to me that regardless of the practice setting, the individual relationship that I have with my patient is intensely personal. And although there's two people in the relationship, so the surgeon isn't in complete control, we can control a lot of things in that relationship and how that relationship may develop. We have to remember that we are asking our patients to trust us individually. Now, there is no question that we may be benefited by or burdened by the fact that we work at an institution that maybe leads people to trust or distrust us, but nevertheless, in an elective situation, it's the patient's trusting of us as individuals that is necessary. And I do think that the responsibility to uphold our patients' trust, namely what I said before, to be trustworthy, is the central motivator of surgical excellence. Why do we engage in CME? Why do we try to keep up with the literature? Why do we read journals? It is because we want to be trustworthy for our patients. So then, how can we emphasize this ethical dimension in surgical care if you go along with me and agree that it is important? Well, I think we need to take seriously how well or how poorly we communicate with our patients. And I think we also need to emphasize the development of communication skills when we talk about optimal surgical education, when we're teaching residents, students, and fellows. And certainly we need to acknowledge the central role of trust in the surgeon-patient relationship. And finally, we have to ensure that we are worthy of our patients' trust. Now, we all know that there are lots of things that we cannot control in our practices. And we know that lack of control is a major source of frustration felt by lots of surgeons in large institutional practices today. No question that loss of control increases the risks of burnout. But again, in the privacy of the exam room, each interaction that we have with our patient is under our control. We can decide how well we do in explaining things. We can control whether we do the things that are necessary to engender our patient's trust. We maybe can't control the length of our office visits, but we can bring patients back for another visit if it's an elective procedure. And so all of these things may be challenging, but we do have a role. And again, we may have lots of time pressures, but nobody can affect how well or how poorly we engender our patients' trust and whether we in fact are trustworthy. So when it comes to mitigating burnout, I think we need to move beyond believing that surgeons are the problem. And I think that there was a time when all of the discussion about burnout led to plans to, you got to be more resilient. We need to teach resilience. And it is great to be resilient, no question about it. I wish my kids were more resilient. Nevertheless, resilience is not the solution to burnout, in my opinion. It may be something that's good to have, but it's not the solution. And I do think that burnout is really multifactorial, and it centers on the moral injury associated with knowing what's right and not always being able to make the right thing happen. And some of you know Jerry Jerkovich at UC Davis now. He said it very nicely, and so I'm going to just quote Jerry. It starts out as little things. Maybe the patient was made NPO for a procedure that never happened. Maybe the patient in the ED needs a follow-up appointment, but there's simply no way to make it happen. Whatever the event, the physician must tell the patient the bad news, that they cannot provide the kind of care the patient needs and deserves, and that they are sorry. Although many efforts are aimed at helping you manage the stress of such a recurrent dilemma, the fundamental correction lies in the healthcare delivery system, not just in physician resilience. So again, there's lots of things we can do, but I would say teaching resilience isn't the silver bullet. So again, how might focusing on the ethical dimension also help? By ensuring the adequacy of the informed consent process from our patients, we engage them in a decision-making process. And such decision-making acknowledges that the surgeon does not always know best and that complications can and do encounter. And having had these conversations doesn't diminish the physical impact of a complication on a patient, but it may reduce the psychological implications on both the patient and the surgeon. So in my practice, it's terrible to have a nerve injury and have a patient wake up and be hoarse. It's a big deal for patients. But it's always a little bit easier if I can say to the patient, do you remember when we talked about this as a potential risk? It unfortunately happened to you. And so having engaged in that discussion, I do believe that it's a little bit easier to have the conversation. So what about the future of surgical care? I do think that there's a value if you ever have the privilege to give a named lecture like this to talk about the future. This is a photo of Niels Bohr, who famously said, prediction is very difficult, especially about the future. The reason that I think it's valuable to talk about the future is you absolutely cannot fact check me on it, right? So you won't remember what I said in 20 minutes, let alone 20 years. And so I'm never going to be wrong, okay? That said, I think that the central challenge for the future and the future of surgical ethics is for surgeons to develop the trust of patients and be worthy of that trust. And again, I think technical ability is necessary, but it's not sufficient for excellence in surgery. Now, we all know there are added challenges to the future of the surgeon-patient relationship. You know, the emphasis on clinical volumes and RVUs pushes surgeons to spend less time with patients. And I actually think that, my administrators sometimes say, gosh, when you're in the OR, you generate a lot of RVUs. You should be in the OR more. I think that for many of them, the solution would be that we actually don't have clinic. We just operate all the time. Of course, what they don't recognize, but we all know, is that we don't get the privilege of operating on patients unless we go to clinic and communicate well with patients and they trust us so that we can do those operations. Of course, the AMR emphasizes interaction with technology rather than with patients. And I don't know if you use Epic in your hospital. I remember when Epic was first rolled out and the person said, who was, training us, said it'll be wonderful. You'll be seeing a patient, you'll have drop-down menus, you'll click here and click there, and when the patient walks out of the OR, your note will be done. And it sounded like this is the promised land, right? I can't wait for Epic. Now, of course, it doesn't work that way, especially if, like me, you don't type very well. If a patient watches me type, they definitely won't trust me to operate on them. So, I've learned a workaround. I don't interact with a computer when I see patients. Again, we know that surgeons are paid to operate and not talk to patients, but we cannot garner trust without communication skills and showing empathy toward our patients. Few other potential issues that the internet places upon us. There are lots of patients who have choices, not all, but many do. There are rating sites. You can Google thyroidectomy scar and see thousands of patients posting their scars. And you can see how many stars I got for things like how clean the restrooms were in clinic. Now, I'm not responsible for that. I just want to point out. Lots of patients compare their experiences on social media. When I see it, I wonder, don't you have better things to do? And yet, it's okay. It's their choice. So again, I would say technical ability is necessary. We have to be good at what we do, but it's not sufficient. And we have to remember, we're dealing with vulnerable patients. Patients have to trust their surgeons to be willing to undergo surgery, and surgeons have to exercise thoughtful discernment in assessing the likelihood of good outcomes. And in the face of the tremendous knowledge gap between us and our patients, we have to ensure that our recommendations are made based on the patient's best interests and not our own. And again, because we can do an operation is not a reason that we should recommend it. So I would say that the current situation we have in surgery and in the foreseeable future is that the central question for surgery has changed. You heard that my father was a small-town general surgeon, Plattsburgh, New York. Most of you don't know where that is, but that's okay. And for my father, in his practice, the question was always, what can we do for this patient? He tells me how when he started in practice, ventilators were just becoming available, right? So there wasn't a lot that surgeons could do. If you had a critically ill patient, you were very limited. Today, the question is much more often, what should we do? There are so many things that we can do for critically ill patients, and sometimes we're not sure what we should do, because maybe we shouldn't do everything for every patient. And again, what should we do is a question of surgical ethics. And so again, rather than surgical ethics being an oxymoron, as I think some people thought 40 years ago, it's actually central to the practice of surgery. I do think that currently and projecting into the future, we are faced with a dilemma. We are increasingly pushed to measure outcomes and quantify results. And this guy you may not recognize, Lord Kelvin, said it very nicely: if you can't measure it, you can't improve it. And quantifying outcomes has had huge benefits for our patients. Unfortunately, it's difficult to quantify ethical behavior, but we still have to encourage it. So you all know Einstein, pretty smart guy. Einstein said it nicely: not everything that counts can be counted, and not everything that can be counted counts. So we still have to demand of ourselves that we meet these ethical responsibilities, even though it's very difficult to quantify that. So I would argue that the challenge in the future is to be a complete surgeon. So again, technical expertise, necessary but not sufficient. A complete surgeon is a technically excellent surgeon who's also a great doctor in the broader sense of the word, to be a doctor. And I do think that surgeons have to withstand the temptation to become technicians, because if we become purely technicians, we're going to cease to be true physicians. And that would be tragic, not only for the profession, but I would argue also for our patients. So I want to leave you with a few conclusions, and then, as I said, happy to have some conversation. I think the relationships we develop with our patients really do matter, and we should take them very seriously. We should think about that relationship as being absolutely central to what we do as surgeons. I do think that trust is the basis of informed consent, much more so than is information transfer. And so, we can have beautiful brochures and we can have websites with beautiful videos that explain operations, but the informed consent process is actually getting our patients to trust us. And that requires some individual communication. I think it's not enough that we learn to engender trust. We have to be worthy of that trust. And attending to the ethical dimension of surgical care, I think, may benefit patients and surgeons. And therefore, I think we should pay more attention to it. And only by fully embracing our ethical responsibilities can we avoid the risk of ceasing to be physicians and becoming purely technicians. And so with that, I really want to thank you very much for the honor of the invitation to give this lecture, and I'd be happy to engage in some conversation. Thank you.
So please come up to the mic. Have any questions or comments?
Peter, that's a great talk. I'm Keith Olamo from Boston. I don't know exactly if it's been 40 years I've been coming to this meeting, but close. The last 3 lectures are 3 of the best lectures I've heard at any surgical meeting over those 40 years. And really, so many great thoughts. So just a couple things.
Thank you.
One, a correction. I thought it was Yogi Berra said predicting is hard rather than Niels Bohr, but I'm sure...
You may be correct. I stand corrected.
Yogi Berra didn't read Niels Bohr. I have 2 different questions. One is somewhat personal, and one is sort of a reflection on OR efficiency. There's a big push at our institution to get operations to start on time. And the surgical consent has become blamed for a lot of that. So there's a big push to have electronic consents. Now, again, you and me and Epic are about on the same level, but I'm not the most proficient on doing anything technologically, but I do sit down with my patients and go over the consent, perhaps not as well as Taylor might do it now, but I still want to go over those facts. And when they're doing a lap chole, I explain once in a while we have to open, and once in a while maybe a bad outcome. And then I have them sign it myself. And again, just like you, if I cut a bile duct, you cut a recurrent laryngeal nerve, I can say, see, I told you it could happen.
Right.
But do you think the electronic consent will depersonalize the entire consent process? And sure, you could say, well, we talked about it. But it's one thing to hand them a sheet of paper with my scribbled name on it and my scribbled writing on it, rather than some electronic thing that I probably had processed and sent to them, and they sign on an iPad.
Yeah, it's a really good point. I think that that is a potential risk. I truly believe that that without us, number one, it's, I think, very important for the surgeon to engage in that conversation. I think that to delegate that responsibility completely to other people is a mistake. I think that it is critical for us to have that conversation. Now, again, in emergency situations, things are different, right? We're talking about elective situations. I do think that some of the differences between the written form and the electronic form may be mitigated by the fact that although the hard copy is a tangible evidence for us, we don't ever give a patient a copy of it to take home. So we keep it, we put it in the chart. My concern is more that if it's something that an old timer like me doesn't really know how to do the electronic informed consent, then I'm less likely to do it, and then it gets, I have the conversation, but nobody signs anything at all, and then they show up in the morning of surgery. So I think that the bigger risk is that we start delegating it to the morning of surgery. Now, I can still engage in the conversation, but there is something valuable about having the patient say, yes, I understand, and I'm, signing the form. So I would say the best way that we can mitigate that is even just in the office visit, writing down the name of the procedure, jotting down a couple things about what are the risks, and I actually give that to patients. I draw on a little diagram, where's the nerve and the parathyroids and things like that. And I think that giving them something is really valuable because, we write down what the operation is that we're going to do for them, but most patients go home with nothing written down. And then they're asked when they come in, what are you having done? So it's not surprising that they say, I don't know, Dr. Angelos is going to do something to my thyroid. And so your point's well taken. Yep, thank you.
The second is a question that's a little bit more personal to me, but it does reflect a lot of people's practices in many institutions. 14 years ago, when I started at the MGH, the head of our PO said, it's a good job, there's lots of opportunities, we've got a couple of little things that might derail you for a bit. And he said, there might be an issue about concurrent surgery at the Mass General. And 2 years later, I was embroiled in the defense process, even though it did not involve my department, and the practices had all occurred before I arrived. And I was part of the defense team to say, well, it isn't unsafe, and it is, et cetera, et cetera. But I was extraordinarily troubled by the ethics of what went on in that practice.
Yes.
And there are still places where it is practiced pretty routinely.
Right.
And there's not a surgeon who hasn't been asked at least once a month, once a week, you're going to do my operation, right, doctor, not some student.
Right.
So what kind of comment would you make if you're a chair and you've got somebody, a chair of orthopedics, I'll make it easy, who's demanding that they have to be able to run 3 rooms because they've got a non-ACGME fellow, they have a nurse practitioner, and they can run 3 rooms. And you have real ethical issues with that. What's your advice on that?
Yeah, boy, that's a really great question. I think a couple things. First of all, I think that because a patient has trusted us to do their operation, I think that does demand that we take responsibility and that we, I can't take responsibility for the operation if I'm not there. Now, I do think that this notion of what are the critical parts of the operation, it cannot be that there are no critical parts. It cannot be that I, as the surgeon, don't need to be there at all. And I am also, I remember early on in the conversations about, concurrent surgery and all, a number of people said, well, how are we going to manage surgical education if we don't let our residents and fellows do things without us? And it really struck home with me that if my best teaching is when I'm not in the OR, then I really have a big problem, and surgical education has a big problem. So I would say, I do think that there are, I think it's okay to have some overlap, but I think that disclosure becomes important. And I think that, if a patient knows that, there's a few different operations going on, I'm not the person who you really need there for the initial, the opening and the closing, but I'm there for all of the critical parts, and these are what they are. And sometimes, patients will say, well, I just want you to do the whole thing. And I say, I don't generally close the incisions, but I'm still pretty good at it, even though I haven't done a whole lot in the last 30 years. But if that's what it takes for you to trust me, I'm willing to do it. And I write a note in the chart that I am personally going to close, and I do. But I think that if we're not willing to explain to our patients what it is that's going on, and we're not willing to let them say yes or no, then we probably shouldn't be doing it. And so it seems to me that that's kind of the criteria that I use. And there are days that I run 2 rooms, and generally what I say to patients is, there are some days I run 2 rooms and I explain, how we stagger the starts and going to sleep and waking up, et cetera. And I said, my nurse is going to come in with a calendar, and you tell her if you want a 1 OR day or a 2 OR day. Most patients say to me, why are you telling me this? I trust you. I trust you to do what you think is good for me. And so if you think it's fine, then it's okay with me. Now, to me, that means that we've engaged in a process that's open and transparent, and I would be okay with. But I think it's a slippery slope, and we need to ensure that we're not doing things that we would not be willing to make public to our patients. Yes.
Dr. House.
Yeah, Michael House from IU. Thanks, Peter, and thanks for delivering an absolutely amazing Moody lecture. We all certainly appreciated that. I think it couldn't be more timely than to start talking about surgical ethics, particularly when public trust in the medical community and public trust in physicians is skyrocketing right in front of us. So I think your call to re-engage with your patients, to build those personal and individualized relationships couldn't be at a better time, because if we're seeing it, whether it's from immunizations, from how we handled COVID, to the lack of transparent disclosures, particularly among proceduralists, including surgeons, who don't seem to understand that it's important to disclose all of their conflicts of interest, and it's going to have to be to the public, and it's going to have to be the responsibility. Maybe just your thoughts, I know we're running out of time, about that issue, about the failure for surgeons in particular and proceduralists to fail to disclose relationships that they have with industry. As you know, there are ways to discover that, but most patients don't have the ability to do that.
By the way, we're not running out of time.
No, we have plenty of time. Yeah, thank you. No, it's a great question. And what I think is fascinating is that, in a forum like this, I have to disclose to you, everyone speaking has to disclose conflicts or potential conflicts. If we write a paper, we have to disclose conflicts. And yet there is no requirement in most institutions to disclose those conflicts to our patients. And so that seems like, why is that, right? It seems like the patients are much less well-equipped than any of us are to understand what are the implications of this. And so I think that you're right. I mean, we have an epidemic of mistrust. I think that's only being fanned by, all the things that are happening in the leadership of, our health systems nationally. But I think that we ought to feel that it's valuable for us to, if we have conflicts, if we're getting paid by industry, if we're choosing to use something rather than something else, and we're also getting paid by industry. I mean, it seems to me that those are things that patients ought to know. There's been some discussion about, surgeon ownership of ambulatory surgery centers, right? And so it seems to me that, a solution is if you have an ownership in an ASC, and you're actually operating on patients in that ASC, there ought to be signs that say, I have a potential conflict of interest, so that patients know about it and it's not dependent on us to share it. So I think your points are well taken. I think we have a challenge in order to rebuild that trust. I think it's possible, and I think the fact that patients lie down on OR tables every day and let us do operations on them is evidence of the fact that we can build trust. But I think we need to work on it, I think, to build that back.
Dr. Soper.
Peter, that was a great talk, and I still remember when you left Northwestern to go to the University of Chicago to pursue your interest in surgical ethics, and I thought, what the hell is this guy doing? Well, clearly you've come out okay, so that's all right. My question has to do with surgical education more broadly. And so I can't remember the last time I did a case start to finish, and virtually always with a resident. And when I see the patient in pre-op, I've already talked to them all about the stuff in the office. That's where you earn the trust. That last minute stuff is just, to make sure everybody knows what's going on. But not infrequently, the patient will ask me, so how much of this are you going to do and how much the resident? And I always kind of have my fingers crossed behind my back a little bit.
Right.
And because I say, well, I'll be the one doing it, but this other person will be assisting and I'll be there the entire time.
Right.
But that's not perfectly true. And do you stay up at night about little things like that, or is that something that is in the name of surgical education and we can just kind of shove it under the rug a little bit?
Yeah, it's a great question, Nat. Thank you. I have to say, I was a medical student and I did my surgical rotations at what was then Boston City Hospital. And I remember at BCH, we had outstanding residents, and once a week, a faculty member would give us a lecture, and that's when I would see the faculty. And so that was a situation in which the residents were really running the service and were doing everything, and much like the VA was during my surgical training. I think that for many, at that time, I felt like, oh, this is a huge ethical issue that, why is there no transparency with patients? I have to say, my opinion changed a little bit when I went from being a resident to being a faculty member, because my very first case was an inguinal node dissection with Dr. Rick Pomerantz. I think he had left by the time you came to Northwestern. Dr. Pomerantz, this patient had a big groin node, and the patient was asleep, and he drew a line and said, make an incision there, and then he said, bovie here and cut that, and I went home and I said to my wife, I did my first case. And I'm sure Dr. Pomerantz went home and said, I could have had an idiot in the OR with me and everything would have gone fine because I told everything to do every step of the way. So I do think that the idea of, what actually is doing an operation is a little bit less easy to understand and less easy to communicate with patients. The way I look at it is, when patients ask me the same question, are you going to be doing the operation? And my answer is yes, but I'm not doing it alone. I am going to have help. And I introduce the resident or the fellow, whoever it is. But I always tell them, but I'm taking responsibility for everything that's happening in the OR. You're trusting me to do the operation, and I'm going to do everything I can to make sure you have a good outcome. And that's the way I address it. And I'm not sure that it matters so much to explain, who is exactly doing what to who when. And there's an outstanding plastic and reconstructive surgeon at the University of Chicago named Larry Gottlieb. Some of you may know Larry. He's a senior guy. And Larry always said, if you have an intricate design on a piece of paper and you are cutting that out, and one person is holding the paper and one person is holding the scissors, is it the person who's holding the scissors or the person who's moving the paper around? Who's doing it? And the answer is both, right? And in some ways, it's not the person holding the scissors that may be more important, but the person moving the paper around. And so I do think that is helpful for me. But I share with you that I do want to reassure my patients. On the other hand, I don't want to mislead them.
Sir.
Thank you, Dr. Angelos, for a wonderful talk, and it's always great to hear you speak. Dennis Ferretia from Virginia Tech Carilion. I wanted to ask the most obvious question regarding the AI in medicine and surgery in particular, What is your take on its implications for clinical care, for research, if I were to move from clinical care to research, and then from what Dr. Soper said, education as well?
Yeah, thank you.
Publication.
Publication, yeah, thank you very much. Those are, huge potential set of ethical issues. I think that, to me, probably the biggest thing in surgical practice that comes up is the extent to which we depend on AI to augment our decision making. And it seems to me that if we are in fact depending on AI to augment our surgical decision making, then we need to disclose that to our patients. And I think that that is going to make it harder to gain their trust. And so I do think that we need to be very careful of the extent to which we do that. Now, many of you may know better than me, but there are, especially for laparoscopic surgery, there are systems that will, the sort of visual recognition on the screen and say for lap choles, the sort of notification that the surgeon has reached the critical view of safety, right? And so you could imagine, well, at what's the threshold that the AI system is set at to say you've reached a critical view of safety? Is it a very conservative one where you really want to dissect things out? There were some surgeons who would do that. And then there are others who are like, you got to keep moving, everything's fine, right? And so how the system is set up, is it designed to maximize patient safety? Is it designed to maximize throughput in the OR? These are things that I think are going to be challenging for us as surgeons to even understand, let alone to be able to communicate these things to our patients. So I would say, despite the fact that AI systems are, getting better and better and better, I think that it may be a little bit longer than we think before we're going to be able to utilize them in a very tangible way in our patient decision making. Now, with respect to surgical education and publishing, I think that those are potentially bigger, shorter term risks. And I would say, I think we need to engage in those who are developing these systems to ensure that the things that we are concerned about, what are the values in our education, what is the value in our research and our publications, to ensure that the systems are reflecting those values. And I think right now, ethics is largely looked upon as providing guardrails to AI, that somehow ethics is going to rein it all in. I think that's a myth. It's not going to happen. What we need to ensure is that as these systems are being developed, there is engagement of people who are cognizant of the ethical issues so that it's built into the system, not that somehow ethics is going to rein it all in. But thank you for your questions.
Peter, there's been something that's been troubling me more and more over the last couple of years, so I'm hoping you'll agree to be my therapist for a little bit. And that is the issue of moral injury. I've seen, particularly with the residents, but even with the junior and senior faculty, that being more and more of like a subterranean issue. It's kind of underneath. It's making people do things that they don't want to do, and it's being imposed, limitations are being imposed upon our trainees and other physicians just because of not being able to do what's right for the patient for financial reasons or whatever those other reasons are. I wonder if you have a way to help me resolve that issue.
Oh boy, that's a tough one. I'm not sure.
I only ask tough questions.
Yeah, no, thanks. I'm not sure I know how to resolve it. I think that, especially for residents, I think it behooves the leaders in departments to take seriously these concerns. And so, if you know the right thing to do, but you are never actually able to effectuate that for your patients, I think that results in moral injury. I think no question about it. And so I think that we have to take that seriously and think about how can the system be modified such that that will not be the case. And so I don't know, I don't have an easy solution other than we can't simply say, yeah, it's unfortunate, you have to get over it.
Yeah, I think we were saying earlier about resilience and burnout.
Right.
It's hard to tell. Again, any physician that, just be resilient when you can't do what you really think is right for the patient.
Right. No, I think that's true, and that's where it does seem to me that it, I think, has been critical for our patients to have surgeons be leaders in systems, health systems. And I think that continuing to have that hopefully will allow for this issue of not being able to do what we know is right for our patients to not get lost. It's, I think, again, reflecting Jerry Jerkovich's quote in my talk, I think that that's a really huge issue for our residents and for our fellows. And I do think that, I for better or for worse, have never been the chair or the chief of a section, and so perhaps I'm placing undue burdens on people who are in these high levels of leadership roles. But I think that them taking these complaints seriously and trying to change the system in some way has huge value. Yeah, thanks.
All right. Any other questions or comments from the audience? Oh, yes, please.
I'm Lee from National Taiwan University in Taiwan, and thank you for a wonderful presentation because we all have the similar issue in Taiwan too. Yeah. So my question is about there are more and more medical advertisement in Taiwan now, and even though the advertisement is about a hospital and even the surgeon individual. So my teacher and I always have a lot of patients. They have very high expectation to meet you because you say, the advertisement or they have search on the search engine like Google keyword advertisement. They say, you are a very great talented surgeon of this kind of surgery. But if we say, about your condition, you are not suitable for this surgery or procedure, they'll get very, very disappointed. So I was wondering how to solve this kind of situation.
Yeah, thank you for your question. I think that, the issue of advertising, I think, is a big one. And I do think that our patients tend to have unreasonable expectations frequently, and advertising or marketing makes those expectations, unfortunately, potentially worse. I would say that a couple things. Number one, insofar as it is possible, we want to be sure that if any of us are being used in an advertising campaign, that it be truthful and factual. And so, many years ago when I was younger, I was on a billboard. Nobody puts me on a billboard anymore. It's, not a surprise. That being said, I do think that we need to be sure that there isn't a suggestion that we can deliver more than we potentially can. And so I think that It's a challenge, and again, I don't know what the laws are in Taiwan. In the U.S., there are false advertising laws, but false advertising means that you are saying things that are materially false. And so if someone says, greatest thyroid surgeon in Chicago, and they have my picture up, it would be hard to prove that that is materially false, because perhaps my mother thinks that that is the case. I don't think many others do, but my mother definitely does. And so I think that, you know, there's a lot that can be done that isn't materially false. So I think as surgeons, the best that we can do is ensure that if our images or our likenesses are being used, that they not be overstating what we can provide. And then I think with respect to an institution, if you can have any influence on your hospital, I think setting, again, low expectations tends to be better than, you know, assuming that we can do miracles. But thank you.
Thank you very much.
All right. Peter, thank you once again for agreeing to be our Moody lecturer. It was a fabulous talk. We had great discussion, and as a token of our esteem from the SSAT, it's for you. And thank you very much.
Thank you very much.